We're now in public session again. We've resumed the meeting. So I'm pleased to welcome from Debra, Dr Sinead Hickey, Head of Advocacy, Ms Deirdre Callis, Family Support Service, and Dr Rosemarie Watson, Board Member. Just a note on privilege, this is just a standard thing we read out for witnesses. Witnesses are reminded of the long-standing parliamentary practice that you should not criticise or make charges against any person or entity, or by name or in such a way as to make him, her or it identifiable or otherwise engage in speech that might be regarded as damaging to the good name of the person or entity. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you'll be directed to discontinue your remarks. It's imperative that you comply with any such direction. Members are also reminded of the long-standing parliamentary practice to the effect that you should not comment on, criticise or make charges against a person outside the Houses or an official leader by name or in such a way as to make him or her identifiable. I now invite Dr Sinead Hickey to make her opening remarks on behalf of Debra. Very welcome.
Thank you, Chairman, and thank you to the committee for the invitation to speak on health services for people with epidermolysis bullosa, EB, on the eve of Rare Disease Day. So, as the Chairman said, I'm Sinead Hickey, Head of Advocacy, Research and Policy at Debra. I'm joined this morning by my colleagues Deirdre Callis, Head of Family Support Services at Debra, and Dr Rosemarie Watson, Debra Board Member and former Director of EB Services in Ireland. So Debra is a charity that provides support for people living with this extremely painful, rare and incurable genetic skin condition called EB. People living with EB are missing proteins that bind the layers of their skin together, so any minor friction causes it to break and blister. In some cases, EB can also affect internal organs, causing internal injuries. On average, about 300 people in Ireland live with the condition. Different forms of EB vary in severity. They all carry debilitating, life-limiting symptoms and pain, with implications for well-being and quality of life. It is an extremely complex condition that can require intensive, specialised care. Wound management is of particular importance to prevent the development of secondary infections, cancer and loss of limbs. In some cases, people need 3 to 4 hours of extremely distressing, painful bandage changes every other day. A 39-year-old woman living with one of the worst forms of EB is best placed to describe the impact of bandage changes. Her condition is so severe it has led to limb loss as a result of EB-related skin cancer. She said, "I dread my mother coming into the room because the pain you endure, there are actually no words in the dictionary." These necessary bandage changes must often be undertaken by relatives, and this has a significant impact on the family and carers' quality of life too. A mother who cares for her 20-year-old daughter, who also lives with one of the worst forms of EB, describes the condition as having a profound effect on physical and mental health. Not only the person living with it, but also their family members. These experiences are in line with the findings of our report, which we launched with the University of Limerick at the end of 2023. This report reviews the evidence related to the impact EB has on the quality of life for people living with this condition. It also examines access to services and supports across 5 countries, including Ireland. And we identified a set of key recommendations based on the results of this research, some of which we will discuss today. The research finds that people with EB in Ireland do have access to excellent supports in the specialist clinics in Children's Health Ireland at Crumlin and St James's Hospital, and community health teams. And I wish to commend the work of these dedicated teams. However, many families face significant challenges and unmet needs for support while managing this difficult condition. Dr Fiona Brown, lead dermatologist for the paediatric EB service in Ireland, says, "As physicians, it's incredibly frustrating to have nothing to offer patients other than supportive care. While there are treatments on the horizon, they are still some years away. We therefore need to ensure that the supportive care that we do offer is of the best standards, equitable and accessed without obstacles." The report found that challenges remain in the unreliable provision of home nursing care for people with EB, including the lack of a contingency plan for when nursing staff are unavailable or move on. As a result, Family members often have to step in and perform bandage changes, inflicting tremendous pain and damaging fragile relationships, often between mother and child. To try and address this urgent need, Debra currently supplements nursing care at home for people in most need. However, we are seeking ring-fence funding and a commitment to recruit for these hours and establish a sustainable service to ensure that people with severe EB can access this essential service in line with their growing needs. The report also highlights the significant impact of EB on the mental health and quality of life of those with EB and their families. This condition can lead to a loss of mobility, impact on daily tasks, and lead to social isolation or loss of work opportunities. This can have a significant impact on mental health. In fact, our findings show that people with EB have far higher rates of anxiety and depression compared to the general population. As a key feature of this condition is living with the ongoing pain and distressing wound management practices, we advocate for specialist supports to help cope with this debilitating condition. A key recommendation based on the research was that extra funding should be provided to help appoint a clinical psychologist dedicated to supporting adults with EB. The findings of this report clearly outline the burden of the disease, emotional and social costs of the debilitating condition, and inform our asks for ring-fence funding, commitment to recruit for a sustainable service, and dedicated specialist support to meet the particular needs of those living with EB and the people that care for them. We hope that the findings of this report can inform the implementation of the recently published HSC, National Rare Disease Office Inherited Epidermolysis Bullosa Paediatric and Adult Care Pathway, a crucial document outlining the breadth of support needed by people with EB across acute and community settings, as well as the HSC Rare Disease Plan currently being developed. To further support this goal, we are currently developing a second project aimed solely at generating in-depth evidence on the access to EB services and supports in the Irish context, to identify strengths, challenges and gaps in provision. Chairman, we would welcome the opportunity to return to the Joint Committee on Health to present our findings next year and any developments since then. However, EB does not wait. It continues to wreak havoc on people and their families living with the condition in Ireland daily. And we hope that these people can be granted the much needed services I've mentioned while waiting for the HSC care pathway to be implemented. We are grateful to Minister Rabbitt's support, which has led to the nomination of Debra as an organisation to receive some supports in the current health service plan that will go some way to relieve the pressures to deliver care for children with EB. We still need significantly more support for specialist health services so that we don't leave anyone suffering with this rare and complex condition with unmet needs. We would like to thank the Health Committee for inviting us here today to talk about our report findings and its implications for the needs of people with EB and their families. And we welcome the opportunity to discuss this topic further and answer any questions you may have. Thank you.
Okay, thanks very much. So who's leading us off for Fine Gael? Bernard?
All right, I'm easy.
Bernard?
I think you go first, I think this time.
Colin Burke.
Thank you very much for your presentation, and I fully understand that it is a very challenging area for parents to deal with, but also for the people that have the medical condition. Can I just ask there, in relation to the appointment of, the whole issue in relation to mental health, that's not just only the person that has the condition, but also, I presume immediate family you're talking about, that they need that kind of mental health support.
You're absolutely right, and sometimes even the care providers, the healthcare professional needs support at times as well, and this is where a psychologist comes in. Carers have a huge job. The burden of EB is enormous, and they don't even get respite and sleep because you have pain in the night and you have itch. So when they come into me, the carers and parents, you can see the worry and the stress and the fear etched on their faces. And we have seen how the introduction of 0.5 of a psychologist to the paediatric service has made an enormous difference. And other international Debras have cited that one of the pivotal things you can do to improve quality of life in these patients and their families is to appoint a psychologist. So we have one.
But are you saying that, where families are dealing with the issue that the local, first of all, not all of these people are based in one area, so you're talking about right across the entire country. You can go from, from Kerry to Donegal.
Yeah.
So, like, your problem then is that if you focus on one person, then they're at a disadvantage if they're in the other part of the country.
Well, I think this is, it'll be shown that this person would link with the community.
Okay.
In terms of Debra Ireland are offering, at the moment, they pay for 12 counselling sessions for people with EB. It's mainly the adults that need it, because we have one in place in paediatrics, psychiatrist or psychologist. But I think that very much people want care close to home, and we're very attuned to that. But we need a psychologist who has an understanding of the whole world of EB, who can link with the community and they support each other.
And just on the smaller issues, I remember when this first came to my attention, I think back in 2014, there was a scenario where, for instance, the cost of bandages wasn't covered by the medical card scheme. And I set up a meeting at the time with the medical card people, and they agreed to include it. I'm just wondering, are there smaller areas like that? Well, I suppose it was a very big issue at the time for parents, but are there issues that could be dealt with immediately where, the support that should be there is not there?
From the bandaging point of view, yes. So people living with severe forms of EB have the cost of their bandages covered under the medical card. However, people living with the less severe forms, the EB simplex, still pay out a lot of money on bandages, not as much as severe, but they wouldn't maybe qualify for the hardship scheme, the medical card, but also these bandages aren't covered under the drugs payment scheme, so they just have to buy them in their pharmacy. A bottle of just a small little tube of Cavalon costs €20. When you're putting Mepilex and Tubifast on top of that, then the costs do add up. So we're looking into the possibility of maybe putting these onto the drugs payment scheme.
Okay, and have you made a submission to the department?
No, we haven't yet, no.
Okay, maybe it might be helpful if it came back to us as well with that submission. But are there other areas where small changes could make a big difference in relation to support for parents and for the people that have the medical condition?
Can I just add as well, in terms of the psychologist, I take your point that, about the community, but the St James's would run multidisciplinary clinics as well a number of times a year, where families are brought up to the clinic, so they would have an opportunity there to meet the multidisciplinary team, and that psychologist would form a huge integral part of that team, where they so the support is there as well in the acute setting, and as Rosemarie said, then this person would be the link then to the community.
Just, finally, just on the research in relation to ongoing care, I mean, it's there for life. I mean, is there much research being done in relation to trying to establish better care plans at the moment, or where are we with that?
So the only management of it now is the medical management of it. And so there's a lot of research done in the biomedical management of EB, so we'll be following those care pathways. And in terms of a cure, Sinead is probably best to talk about that. There are gene therapies available. Right now they're just available in America. We are hopeful that they'll be available in Ireland in the next few years. But right now, it's psychology support and the medical management of it. That's what we need right now.
Okay.
Sinead, did you want to come?
Yes, we can talk about. There's no cure, there's no treatments for EB, so it's very much management of the condition at the moment. We do have a submission from a company with the NCP at the moment to reimburse drug to help with wound healing. So we hope that will be successful. And there is a gene therapy that's been approved by the FDA over in the US. It's a topical treatment to help with the wound healing externally, and it's showing very positive results. So they have just submitted to the EMA as well. So we hope to see that. But again, it's going to be a few years off. And in the meantime, we need to...
the coordination at European level, is there coordination at European level as regards advancing the care and improving the care.
Yeah.
There is through Debra International. There are research projects that are shared, and Debra Ireland contributes significantly to the international research, but also they are promoting research in Ireland through linking with government agencies. So I think that's going very well. And I'm 30 years in the area of EB, and I never thought in my lifetime I'd see a chance of cure. And the gene therapy available now in the US, approved by the FDA, it has been in clinical trials and in clinical use for 4 years now, and you can use it in children from as young as 6 months, and it's healing wounds, and it's also preventing the wounds from breaking down again because it's replacing the missing protein in the skin. So this is very exciting. We're not there yet in Europe. They have not applied to the European Medicines Agency for it, but it's going to come because it's a complete game changer in the management of this devastating condition.
Thanks very much, Colin. Deputy Pauline Tully. Thanks.
Well, good to hear that. Good morning, and you're very welcome into the committee. And I want to first of all commend you as a charity, because I know the absolute wonderful work you do for people with EB and their families. So it's tremendous. Just in relation to a follow-on from what Colin asked there about the bandage scheme, I mean, there have been requests. I know one of your asks is a national bandage scheme that's operated in other countries. I think, is it Australia have one and so on. Are we getting anywhere closer to seeing that being realised? Because I know from talking to people with EB before, sometimes the bandages they receive are not the right size, or they're not sufficient quantity, or they're late, coming to them or whatever, and it can cause severe problems if the correct bandages are not available, like there's a risk of infection. So is that being considered at the moment?
There's two issues there. There's one around the covering of the bandage financially, and then the whole process of issuing the bandages. So yes, you're correct. People with severe forms of EB, their bandages should be ready to collect at the public health centre monthly or whenever they collect them. And I don't think there's the awareness of the importance of the sizing. So they might get a size that's too small, who the suppliers might think is fine, but without understanding the condition, when in actual fact they can't use it. So they have to go back and look for more, which is a lot of pressure on parents who are already struggling trying to coordinate all of the care in the home, and then having to try and go back with issues with bandages as well. So it's about fixing the system, I suppose, and building awareness there, as well as making sure that there's a bandage scheme for all people with EB in Ireland. Australia have a fantastic scheme where the bandages are delivered to the house every month for all types of EB, doesn't matter how severe or how not severe it is. And also I think Spain and the UK as well. The UK have one particular supplier through pharmacies, and again, once they have a note from their clinician explaining what bandage types they need, that's all organised for them, and they get that ongoing.
Types of EB as well.
Yeah, and all types of EB.
Okay,
and it'd be lovely to see something like that in Ireland as well.
EB is not included in the long-term illness.
No.
I don't understand why that is, but what benefits would that bring if it was included?
Yeah, so if it was included in the long-term illness, it would allow all families living with all types of EB to be able to access the medication and the dressings and the equipment that is specific to their type of EB.
Okay.
Right now, as Sinead and Rosemarie have said, there's a whole cohort of people missing out. They either earned too much to get the medical card, or they're not. So they're falling between the cracks.
Yeah.
And the long-term illness would absolutely align with what we would think is the right direction for people living with EB.
And why is it not included? Because it's not curable. It's a long-term illness.
True.
Yep.
I'm just wondering why. What's the reason given? What criteria does it not meet? Or
it's something that we have to consider. But I think there is this. I hate using the word mild because there's nothing mild about EB, but because of the different severities, that causes complications. So it is something that we have to consider, and something that is on our agenda to bring forward to really advocate and lobby for that going forward.
I know in relation to carers, you identified that there are insufficient. We know there are insufficient carers in the community, but we really need to see specially trained carers, don't we, for people dealing with the EB again? Because I mean, if there's a changeover of carers at all, it means somebody starting from scratch, not knowing the extent of. So I mean, we hear from the department all the time that the money is available, but the carers just aren't. So I mean, what we really need, is there a possibility of looking at specially trained carers for people with EB?
I suppose that's the biggest challenge that parents and carers of EB have at the moment. It's huge stress. So the home care nursing is subcontracted to agency nursing, and there's a huge. I mean, it's not an easy job. Doing a 4-hour bandage change, inflicting pain on a child, it's horrendous. So it's a very niche area for a nurse to stay in, and there's a real struggle around that. And we've had much experience of nurses being trained, and it's specialist training that they need, and then moving on. So with the agency care, I think there's a lot of turnover. So we get a lot of nurses moving on. I think one parent was saying in the AV room there last October that she had 39 nurses in 1 year. I think it could have even been one season. Mm-hmm. So there's a huge struggle here. I mean, we know that there's an issue with supply of nurses in general, but then when you ask them to go into this niche area, so this is something that we're really asking to really kind of implement a sustainable service where we can have a care coordinator who can coordinate all of these nurses, so that the parents don't have the stress of having to do that and not have to worry about what nurse is going to cover next week when my nurse is on annual leave, or if a nurse moves on, we have to start this training all over again. And then having the outreach nurse in place as well for the adult services. We have a fantastic system in place for the youth services at the moment, so putting that into the adult service, so we have these nurses coming from the acute setting coming into the community and actually training these nurses and giving them support as well, to help them kind of stay as well, and do something around the price point of nursing to make it more attractive for nurses to stay in this setting, because that's the biggest challenge at the moment for people with EB, I think.
I would agree with you, Sinead, that there's a real problem with retention as well as with recruitment. And from the retention point of view, the appointment, if we can get the monies for an adult outreach nurse, that they will support the nurses that are leaving now. So that I think that would make a big difference. All right, and there was something else I was going to say. Oh yeah, that from the retention point of view, that they find the hours are difficult. The nurses, like they're approved for 3 to 4 hours 3 times a week, and most nurses want more time than that. So if we could try and find a solution for that would be great. But increased remuneration, because I think these are complex care nurses. They're very it's a special niche, and they are very special people that will make a huge difference in people's lives. And so I think there probably are nurses out there who would like to take it on, but don't feel they have that flexibility to just take on the 3 hours 3 days a week. I think remuneration would go increased remuneration would go a long way to help keep them. Yeah.
I know my time is up, so I'm conscious of that, but I just want to very quickly mention the economic burden on people with EB. It's massive. So I presume that includes having to purchase all the services. Yeah.
Bandages, hospital visits, everything. I mean, Debra do support them with grants as much as we can, but there's huge financial burden on top of it. If you have a new baby born with EB, you've lost a life you knew before. I mean, most of them are inherited recessively, so they've no idea before the child is born that they have EB. A parent usually has to give up their work, their life to care for this. So there's a loss of earnings from the parent having to give up work. There's no contribution from the child when they grow up. They won't work either. And then when you include hospital stays, bandaging costs, and costs for PAs, home nursing care, it all adds up.
Thank you, Chair.
Thanks very much. Roisin Shortall's next.
Thank you, Chair. And good morning. And thanks very much for the work that you do in advocating and supporting families dealing with this issue. I just have a number of questions. You told us that there are about 300 people in this country living with EB. What kind of prevalence is that? Is it? Would you say it's kind of standard, say at a European level, or?
Numbers usually increase. A little bit of immigration. With immigration, there are increased numbers where there is intermarriage amongst cousins, etc. But our numbers have been fairly steady and are comparable with other other countries. So it's about 1 in 16,000 births will be affected by EB.
Okay, and that doesn't vary much depending on
No, as
the
I said,
country.
immigration may change that over time,
Okay.
but at the moment that number has been fairly steady.
Yeah, okay. Certainly the information that you gave us there in relation to progress on gene therapy is very encouraging. And
It's amazing.
yeah, as you say,
They will need nurses in the home to be able to access that therapy, because the healthcare professional has to apply the therapy on the wounds. It's a gel that you apply. So this is another reason for our ask for nurses. We want it all in place
Sure.
when the time comes.
Right, okay.
for
And
that
have you
time.
any indication of when the application may be made at European level for the new
So
treatment?
it's happening at the moment, and they're just getting their submission together, so it should be any day now, hopefully. And then we hope that, I presume that'll take the 18 months to come through, and then it'll be accessible then in countries like Germany and Austria, and then we'll have to go through the NCP process then after that.
Okay.
And for reimbursement.
Okay, that's very hopeful, obviously, for the future. Can you just explain to us how the system of supports operates at the moment? I mean, is it a question of people qualifying on income grounds for a medical card or not? Or are there other supports given the nature of the condition?
So right now, if paediatrics, the main support would be ourselves or Crumlin Hospital, and then adults would link in with St James's Hospital and again ourselves. But in terms of in the community, the more severe types of EB would have access to all bandaging and all the equipment that they would need as well. But the milder, and I use that term very lightly, the milder the diagnosis, the less is available to you.
Okay.
So a huge cohort of our families living with simplex work, so that would max them out of applying for a medical card, and even the €80 on the drugs payment scheme, if the dressings are on it, which a lot of them are not, they still have to pay €80 a month to access a certain amount of dressings. And as my colleagues have said earlier, it's not a case of even swapping out for cheaper ones. You can't. These are really specific dressings that can only be used, and the price point is incredibly expensive.
Okay, and I'm just wondering, I mean, are those dressings and the treatment, are they on prescription?
They're available, some of them, not all of them, but the more the severe cases will get them because of the severity of their EB, but not all of them are available on prescription.
Okay, I mean, that seems like a fairly straightforward decision that could be taken, which would be a huge help to people. And you talk about severe and simplex, and I don't think there's anything simple about the simplex cases. But what is the kind of split, say, within that cohort of 300?
It's about 70-30, wouldn't that be right, Rosemarie?
It's the milder forms and 30 the more severe forms. Yeah.
Okay.
So it's the majority of the people.
The majority of people living with EB in Ireland
have a problem with accessing the right bandages.
Or again, sorry to across, it's just started popping into my head, and I better say it before I forget it. Even the mobility, if people living with simplex had access to bus travel, that would keep them in employment.
Sure.
A lot, if they had a blue badge, that would again keep them in employment. We have had huge problems with people not being able to park near their place of employment and having to walk there. Their feet are like blistered by the time they get to work.
Sure.
But they have nothing to demonstrate that they have this condition.
Okay.
So that might be another thing that we could consider that might,
Okay. Can you just talk to us about pain relief and the role of pain relief and also the support available for it?
Obviously, this is a very painful condition, and 30% of people with a severe EB will have open wounds of over 30% of their body, which is an awful lot. So right from birth, we give pain relief. Paracetamol isn't just going to do it. A number of them require opiates, but we also, in paediatrics, we use play therapy to help with procedures to reduce pain. Again, psychology is another very useful holistic look at helping pain. The majority of the severe patients would probably be on opiates. And lots of other things have been considered, even the cannabinoids in international studies, they're beginning to look at that.
Okay, so I take it all of those would either be available on the medical card or on the drug payment scheme?
We actually do well with medications. I think they're usually available.
Okay.
I don't have a problem with that.
Okay. Just on the question then of the specialist nurses and the dressings, and clearly it's a very challenging role and a difficult role. Is it essential that that service is provided by nurses?
It's a good point. Maybe you can add as well, Deirdre, but with some families have a healthcare assistant. The problem there is that they cannot work independently. So if the nurse is off on holidays or sick, they can't. They can just hand the bandages to the nurses, essentially. So if the HCA rules changed, we might be able to access more help there. But the ideal standard would be nursing.
Okay. Just something that is quite shocking, I think, is the fact that yourselves, you have to provide so much financial support to people that isn't available from the state. I mean, it's pretty shocking given the nature of the condition. So can you just tell us, sorry, two questions. Have you met with the Minister recently in relation to your budget asks? And secondly, how are you funded?
Now, oh, do you want to say something?
Yeah, we have requested meetings with the Minister on a number of occasions over the past 2 years, but we haven't been successful at the moment. So we will keep asking.
Can I add to that? I have met with several ministers over the 30 years, and but what I have to say, I think it's the HSE have come through for us over the years. The service is unrecognisable now from when it was 30 years ago. We had patients who were using J-cloths for bandages with ointments on them. So over time, the HSE has listened to their credit, and they have given us the funding for the adult and paediatric hospital services. And we are deeply grateful for that. And I think we compare from that point of view very well with other countries in Europe. In fact, I'll tell you a little story where we were really proud of what we had gotten, because an American microbiologist, lab technician, came to St. James's Hospital. She was on holidays and she got an illness that required surgery. And she was in the emergency room telling them about EB, and because she was very worried, because when you go into an operating room, you have no control, you're asleep, so people can do damage to you unwittingly with tape and blood pressure monitors, etc. So she was telling them about it, and the emergency room doctor said, oh, you need to see our EB specialist nurse. And she looked, and she said, oh my God, in all my years in America, she said, I had never met an EB nurse. So, do you know, the HSE...
That's good to hear. Just on the community services then?
Yeah, it's the place we have the gaps are the community services. There's no doubt about that. So you were asking me about funding for that. The HSE have listened again, and they have given us the funding package for all newborns that are born now with severe EB get it, which is wonderful. However, the package has some problems. You have the same package at birth as you might have at 18. Nursing requirements, etc., all change over that time. So we need more flexible packages, and we have to go back for that battle, as well.
Thanks very much.
Thank you. Nessa Horrigan's next.
Thank you. I might stay on the community support side of things and some of those more subsidiary supports. And just to say thank you so much for your opening statement, but also the report, the more detailed report, because it's great to see a report that focuses so specifically on well-being as a result of a condition. We don't always get to look at it in a holistic way. So I suppose some of the ones that I picked out were around mental health and around dental care, and I noticed that in that longer report there was an issue around dental care and that accessing dental care, and the report kind of states, well, the kind of centrality of Dublin alleviates some of that, but that, for example, in Austria you undertook training of kind of specialists in dental support. I'm just wondering, can you expand on where we are in Ireland with that, the accessibility of dental services for people experiencing this?
So at the moment, again, if you're under the acute settings care, you can access dentistry through that. However, again, for the less severe forms of EB, it's a lot more difficult. We are trying to do a piece of research on that with the dental nurse in Crumlin and also with the University College Cork, but we've been unable to get funding for it at the moment. So we hope to do that
For the piece of research?
Research to get access to dentistry, to get an understanding of what the barriers are. And again, we have one dentist in Crumlin that is specialised in EB, but then there's no knowledge around dentistry for other dentists out in the community.
You often find they're nervous.
Yeah, they don't want to.
Community
I
can understand.
They can cause a lot of damage, because patients will get more blistering when they go to the dentist, even the best trained dentist. So dentists in the community will be nervous, but support from the centre, that is our problem, is the community. Because in dentistry you can't be coming back and forth to the hospitals all the time, because there are often frequent visits, and so that's something we can improve on.
So anecdotally, do you believe people are travelling distances to come to Dublin, for example, from down the country for dentistry?
Yeah.
Okay. And then in terms of physiotherapy, then there was a piece in the report on that. Are we talking, you mentioned physiotherapy in the community. Am I to understand that is that home care or in a primary care setting?
In a primary care setting.
Okay, and what's the access like there for special? I presume that again is a specialist requirement because you're manipulating the limbs and.
Yeah, the local physiotherapist would need to have some basic EB training from the mothership, so to speak, because their role is to help strengthen and stretch the limbs, and there may be a role in splinting as well of the hands, and so they would need the support. And at the moment, I think it's difficult. There are some local physiotherapists helping out, and our physiotherapy department always tries to link in the hospitals. Always tries to make a link in the community, because again they may need frequent visits.
So if a primary care nurse was looking, or sorry, a physiotherapist was looking to access training in this, are they going to yourselves, or can they access that through their own training?
They would have to link in with either St James's or Crumlin.
Okay.
They would have to link in there.
But sorry to interrupt. The outreach nurse would play a big role there in education, and would probably attend some of the early visits with the physiotherapist, so that they become familiar and comfortable with what they're doing.
And I suppose anecdotally then, because I know you're not running the primary care centres, do you believe that is regionally, is there access to that regionally in communities? People with that kind of training?
Training in EB or
EB specific physiotherapy.
They would have to be taught it, but I had to be taught it when I went into it.
But are there staff in primary care now that have that training in place?
In the community?
No.
No. Okay. And then I suppose finally, if we could just expand a little bit on mental health supports, because that came up throughout that report, the huge burden in terms of mental health. And, we've talked in this committee before around the very specific needs of people with medical conditions and the types of supports they need. Again, is that accessible? Are we getting that through primary care? Are people going to private providers? What's your sense of where that is?
Yeah. So right now, Debra funds counselling for people that are linked in with Debra. So we would fund a minimum of 12 sessions, and that can be extended to 24 depending on the need. So right now we're funding that privately with families. We need a 0.5 psychologist in St James's Hospital, and again that would allow families to be able to access psychology when they attended their MDT, which is about a few times a year, a couple of times a year. But no, we're currently funding.
So you are funding?
Debra are funding.
So the HSE through primary, there's no...
There's long waiting lists. It's very specialised. So we fund now, we fund counselling now for families that are...
Okay, and is that similar across paediatric and adult?
Now there's a fantastic post in Crumlin at the moment where there is a 0.5, so we're definitely seeing the benefits of that already. Okay. But currently the people that would access the funding from Debra, majority would be adults. We have funded some play therapy for some sessions, but the majority would be adults, yeah.
Okay, and then
carers.
we have started a discussion, and I think we're all delighted to hear that there is some work being done in the US, and there is kind of research on the horizon or treatment on the horizon. But I think you said that it was a genetic-based treatment?
It's a genetic.
Okay.
Yeah, well, there are other treatments coming in the pipeline as well. And I think people with EB in the next 10 years will find that there are several treatments that they're facing. Because the gene therapy is for one specific form of EB. It's one of the most severe, but it's for them. But there are other drugs being repurposed from other areas that may benefit EB patients. And there's the other wound healing agents that are coming on board that are showing a significant difference as well.
I know I'm out of time, Chair, but just to follow up on that, as it's in the kind of the realm of gene therapy, do sufferers get access to genetic counselling currently?
Well, certainly in the they do. We have a good relationship.
Particularly families who are making decisions around.
We do have good relations with the Department of Genetics. Yeah.
Okay, thank you.
Can I just add that from the psychologist point of view that yes, I wanted to say that the importance of having a psychologist in the hospitals as well as the community is that a lot of people don't want to go to a psychologist. There's a barrier there. And in Austria, nobody wants to see a psychologist. But here, if you have a psychologist there who meets them with the team from day one, they don't see it as abnormal then.
Okay. Thank you.
Kenny's next.
The idea with that as well is that the psychologist, by meeting them in their clinic appointments in the acute setting, builds a relationship with them. So then when crisis hits, they have that relationship built and they feel comfortable to approach that.
Deputy Gino Kenny.
I'd like to welcome Rachel and Casey to the public gallery.
The boss.
Yeah. Hey Casey. Hey Rachel. We'll have a chat with you later on. Thanks for coming in today. It's been really enlightening. And fair play to you for all the really good work that you do. Just a number of questions. So I'm going to ask questions that the others haven't answered, because obviously 5th or 6th in a row. So in relation to in environmental conditions for somebody with EB, obviously direct sunlight would be detrimental to, or maybe wrong on this one, but environmental factors. What kind of what factors does that have to play in relation to exposure, in relation to light and so forth?
It does limit people with particularly the more severe EB. Sunlight, definitely. Their skin is much thinner than ours in areas, and that would be something they would have to protect against. Heat vastly increases the blistering, especially when you're under heavy bandages, and that can be extremely uncomfortable. Extreme cold or wind can cause burning sensations on the skin. I'm trying to think, are there any other environmental?
Just in fact, like even being out in the air, like if Casey didn't have her dressings on, the bandages are her skin. So if they weren't there, then she's absolutely
she'd be more prone to infection.
Yeah.
I would say the Irish climate, obviously it's not particularly, it's a kind of,
I think the Irish climate, it's not the worst. I've been in Australia and seen them come into their clinics in their flip-flops and whatever. I was actually amazed they were able to wear flip-flops with their feet. They acclimatise. But I think we're not the worst country we have a more temperate climate.
And in terms of new treatments and gene therapy and all that, you did mention the issue around medical cannabis. Medical cannabis?
Yeah.
Cannabinoids?
Cannabinoids, yeah. So
because I was just looking up the research actually around it. It's actually quite good.
Yes.
Yeah.
Quite good.
Yeah.
Do you have any has medical cannabis been used in relation to treatment of EB?
Yes, and there's research. Do you want to add to that?
Yeah, no, it has been used for adults. Yeah, absolutely, and it does make an impact. Yeah, so it is good.
Would that be in terms of an ointment or a medication for pain relief?
There's two technologies being developed at the moment. They're in clinical trial phase. One is an ointment, so a cream that you can put on the skin, and the second one is the form of a drop that's placed underneath the tongue. And they're in clinical trial phase at the moment. And,
I was just reading about that in Britain.
Yes.
And that's very interesting, actually.
Yeah.
And do you know anybody that has, say, has been prescribed medical cannabis for EB in Britain or Ireland?
Well, I know, yeah, we have some adults, that are accessing that at the moment.
Ireland?
Yeah, absolutely.
Okay, that's interesting.
Yeah.
It won't replace other pain meds,
No, of
but
course.
it will be a very useful adjunct, we think. Yeah.
And are they getting it via licence, or I presume they're getting under licence?
It's through prescription. Yeah, it's through their hospital. Yeah.
Okay.
Yeah.
The medical cannabis access program, no.
I don't know,
No.
actually. I don't know. It's
I'm
only
retired, I wasn't doing it in my time.
Okay, I'll have to do a bit of research on that, but that's interesting. You know, it's a
we can
field
come
that I'm
back to
very
you on that. Yeah.
Sorry?
We can come back to you on that.
Yeah, it's a field that I'd be very interested. I think that's it, because everybody has really asked a lot of the questions I was going to ask, and I don't want to be kind of repetitive, so I'll give her over to my esteemed colleague. Whoever's next.
The next esteemed colleague is Senator Annie Howie, who's
Already.
online.
Hi, hopefully you can hear me okay.
You can, yeah. You're on the
Great,
grounds
thank you.
against the house.
I am, yep, I'm in my office. Can't you tell from me being floating out on the plinth there in front of everyone? Thank you so much. I don't, you've covered so much here. I suppose the two questions I have. One is in relation to what is the training pathway for specialists in this area? Like, you know, we've all the figures around consultant post not being filled, but what actually, I'm interested in, what is the training pathway? What is the speciality someone has to go into, and what is the uptake of that, or what if you're looking across the system and people coming up through the system, is there any concern in terms of having those specialists, or is there a shortage, or just what's around that? And then my other question is around the carers allowance. If someone is caring for someone with EB, and within all of the other systems of being under the threshold and stuff, is that an illness that would qualify someone to be able to claim either the carers allowance or the domiciliary allowance if they're under 16? Like, how does that work between those who are caring and if they were under the threshold? And those are just the two questions. Thanks.
Yeah, very good questions. In the past, the specialists, first of all, consultant specialists, that there are about 17 of them in the hospitals that EB patients attend. But the lead specialist in most countries is usually a dermatologist because of the large amount of wound care involved. How are we trained? Mine was on the job, but that's a long time ago. But nowadays, first of all, we're trying to attract people in because we had a long gap where we didn't have an adult consultant. So Debra Ireland are teaching in the universities to try and attract medical students early, and some of the EB patients have actually gone to the universities to talk to the students, and that's been a very positive experience, which we're very grateful to Debra for. One of the problems in paediatrics is that by the time the dermatology trainees get to us, it's usually year 3. They're more experienced at that time, but the downside is they've tended to make up their minds that they're staying in adult dermatology or they're not going into EB. So we do have a little problem to work on in that area. We get our training through the international conferences. We have gone individually. Great Ormond Street trained us when we opened our first EB clinics in 1996, I think. They actually sent their team over, a physiotherapist, dietitian, nurse, and they were with us for about 2 years as we did our clinics. So that was absolutely amazing, and that was courtesy of Debra UK and the people at Great Ormond Street Hospital. So that's generally how the training occurs. As regards the carers allowance, Deirdre, do you want to?
Yeah, so most parents with severe types, with their children having severe types of EB, again, will qualify for carers allowance. But as my colleague Sinead said there, it also, one parent will also have to give up employment to become the full-time carer. So an income that might have had 2 strong incomes prior to this is now down to €200 and odd a week. So it's a huge discrepancy in their earning capacity before it to now. Yeah. Hope that answers your question.
Thank you.
Yeah, that does. Great. Thanks very much.
Thank you.
Okay, thanks very much. I'm going to go to Bernard Durkin.
Thank you, Chairman, and I thank our witnesses for giving us the benefit of their advice this morning. Can I ask a couple of questions? In relation to the condition in an attempt to alleviate the pain and the suffering, the distress to the patients and to their families, to what extent has it being deemed appropriate to have a full medical card in each case because of the ongoing nature of the treatment and requirement above and beyond what would be regarded as normal, and keeping in mind the fact that patients associated with cancer or life-threatening illnesses have always been deemed to be entitled to avail of a full medical card.
Yeah, and that's where we're going. That's what we want. We want people living with TB to have full access to a medical card, regardless of means. So that is one of our hopes. And right now, there is, as I say, if you are not living with the more severe type of EB and you're working and the threshold of your income into your home is over a certain amount, it just disqualifies you from accessing a medical card. That's the current situation at the moment. But it would be our hope that we either move on to the long-term illness, which would give access to medical card equipment, medication, or that we get a discretionary access to people who are living with EB, which is a long-term, it doesn't go away, that if we get a discretionary letter to say that because you have EB, you can have access to the medication and the bandages that are available on the medical card. That would be our hope.
To what extent has there been access to pain alleviation clinics because of the nature of the illness and the treatment of the required? What about pain alleviation and
Definitely.
And does it work?
There are pain specialists, and that's what we have lent on them a lot over the years in both Crumlin Hospital and St James's Hospital. I know the pain specialist in Crumlin left. I don't know if they've been replaced, but when they haven't been available, the anaesthetists in the hospital have helped us because they're often on very strong doses of medication, so we need their input and advice. So that does happen for those that need it.
To what extent are rare or orphan medicines required and access to such treatment? To what extent is it available? To what extent is it ongoing? What are your expectations in that area in the short term?
Yeah, well, most of the medications we've not had a problem with, except the ones that are not covered on the medical card, but you can apply to the hardship scheme for those. Now, when treatments, we don't know what's going to happen with the birch tree pollen.
So there's a product that's with the NCP at the moment, and there's a number of people in Ireland using it on compassionate use, but we hope that will be rolled out, if it's approved for reimbursement with the NCPE, that will be rolled out to all patients with severe forms of EB.
When you reached out to Great Ormond Street and they responded, to what extent was there a noticeable improvement in the availability of services or medicine or action in general in relation to that particular illness?
Well, I think when they came, that's back in the 90s. When they came, they brought with them the specialties that make a lot of difference in the day-to-day lives of people with EB: the dietitian and the physiotherapist and the doctor and the nurse. The nurse is the key. So our hospital. Not just me, but our nurses, everybody learned from the experience, and they stayed with us 2 years to embed that information, so that we felt we got great training. And so I think for our families it was night and day. We had Crumlin was the only place they were coming, so we actually saw a 33-year-old in Crumlin Hospital. I think we must be the only specialty that ever did that, because she said there's no specialty, there's no adult service, I'm coming to Crumlin, and she was coming, so it worked out fine. But obviously we don't have to do that now, which is good.
To what extent is there a standard approach, a regime for treatment from the time from children into adulthood and follow-up? What extent does that exist? Is there an organised programme of dealing with the situation?
Yeah, well, we've put in the care pathway to the Rare Disease Office, so that's with them now, and they've published it. And the hope is that the HSE will back all of the services that are required from that point of view. oh yes, they're also, Debra International have internationally agreed guidelines for the care of several areas, and they must have about 10 or more guidelines now, and included in that is psychosocial management, emergency management, operating room management of dental management is in those guidelines, which you can get at the click of a button now. Anyone can get those. So that's a huge improvement over my time as well.
There's also the establishment of, so EB is a rare disease, so it's important that the International Rare Disease EB community work together. The Crumlin is an expert centre that's part of the European Reference Network for Skin as well, so there's a group of European dermatologists that work together to troubleshoot for EB as well. And then the Debra International as well brings a lot of the experts together to publish these clinical practice guidelines that can be used not only in developed countries but also in those countries that don't have clinical services for EB.
I would commend you on the work you have done, the very constructive work that you've done, the manner in which you've gone about it, and the methodology used to deal with the situation, appease it as much as possible, ameliorate the discomfort, the pain and the suffering for the patients. I think that we should, Chairman, pursue that further with the Minister with a view to seeing what further help can be made available. Thank you.
I'm going to move to Senator Martin Conway next.
Yeah, and I would concur with what my colleagues have said here this morning, and I suppose to welcome you and to thank you. I first came across this issue, I'd say about 3 years ago, 5 or 6 years ago at this stage. And I've always taken an interest in it, and it's great, I suppose, looking at the positives. It's great that there is some developments in the US, and of course it'll probably take some time for it to percolate down here, which is always an issue. One thing I would be interested in hearing your views on, is there any support being provided to the siblings of children with EB? Because I'm sure as is often the case where somebody has a disability or an issue in a family, sometimes siblings can be affected in ways that isn't known. So I'd just be interested to hear, because of the nature and the obvious pain that happens, surely it does have an effect on siblings.
Absolutely. I mean, our counselling grant is available to any family member. That's the first thing to say, and also in the acute setting, that is extended to the families as well when they're accessing the acute setting. But interestingly enough that you brought that up, a couple of years ago we introduced in Debra the sibling appreciation grant. So it was whereby the person living with EB had to nominate their sibling and tell, and just create a bit of space where the acknowledgement of being a sibling to somebody with a chronic illness was really, really important. And it's one of the little things that we do every couple of years that is really, really embraced by families, and it just quite rightly, as you said, highlights the role that siblings play in the family living with EB. But we do, as I say, we do extend our counselling grants to all family members.
And would many families take up, many siblings within families take up that offer?
No, it's low. It's low. And we have had some people do some play therapy if they're in that age, but it is low, so there's a gap there.
Okay.
Debra continue to work on that, and they're to be commended for all of the work they do to bring joy to the families of people with EB. You have so many programs, Barrettstown, so many programs that they do year-round, Santa Claus, they're just wonderful. And I know we would not have the service we have today without Debra. They really got us on the road and have raised the awareness of EB so that people, my friends who know nothing about medicine, have heard about the Butterfly Children. So that's a credit to Debra. And thanks to the HSE for funding the programmes for us. It's made a huge difference.
It is rare that people come in here and actually have good things to say about the HSE.
No, we should.
Even though the HSE does lots of good work, and they're a great organisation, but it doesn't get acknowledged. And look, at the nature of our committee is that we're there to stress test and deal with issues that the HSE aren't responding to. But it's good to just get the other side as well. So thanks very much, and well done on all your great work.
Thanks a million. Thanks for having us.
Thanks very much. And Martin was saying that the first time he came across it was a couple of years ago. It's a long time ago since the first time I actually heard of it. It was a cousin of mine was having a significant birthday, and he decided that he would donate. We would all pay into his birthday, and there was funding. It was a fundraiser for Debra, and he outlined to us that night the nature of the genetic disorder, and I think we all came away with not only enjoying the night, but felt that we were doing something positive for a really good cause. And I'd probably recommend anyone else that wants to have a significant birthday maybe to do the same. Just on a couple of things, and I know we touched on it today, but you talked about the impact of the disorder. You mentioned diet, and maybe you might expand on that. Is there certain foods that you can eat and not eat?
There's that as one part of it, but there's huge calorific needs for people with DB because they're wound healing. And that's extra work the body has to do. So they need to have a big increase in calories. And yet at the same time, they've got blisters in their mouth, blisters in their throat. And so certain foods they can't eat, anything that will aggravate that blistering. You do need a lot of protein in your diet because you're making protein, you're healing your wounds. The dietitian is there to increase the calorie intake for these children. They take a lot more than you or I, and adults, a lot more than you or I would. Sometimes they can't take enough calories in through their mouths, and we offer them feeding tubes to get the extra calories in. So it is complex. Needs a specialist dietitian.
I'm conscious that there's layers in the audience, but and a parent. But again, the actual disorder itself, you were saying about the challenge that if you don't have that specialist nurse, that changing the bandage, the idea that the last thing any parent would want to do is hurt their own child, but that's that's what's happening. Mm-hmm. Do you want to explain that to us? Maybe just what's involved.
Well, I think the patient mentioned it, that Sinead read out about, mentioned it very well, that she just dreads the mother coming in the room. If they know it's bandage day, and that's a big fear because you're inflicting pain, and everybody's upset. Child's upset, parents upset, siblings upset. I mentioned the siblings there. Having an extra person who can take time to make sure the pain meds are in there before they start the bandages. There are tricks to help not pull off sticky bandages, but by soaking them for X amount of time. An objective person like the nurse can look at the environment, can see music on, anything that will lessen the discomfort and pain during that time. But unfortunately, it's there, and they have to go through those dressing changes. Otherwise, you face infection and the complications of that. So it has to be done, unfortunately.
But also the relationship between the mother and child as well is so important, and it really puts such pressure on that when the parent has to inflict that pain. Whereas if somebody coming in that's more objective, that can control it better, but also removes that stress on the relationship of the parent inflicting the pain on the child, especially at a young age.
So you were saying there's approximately 300 people. Is that on the island of Ireland or just the south of Ireland? Is there a similar organisation that does operate on the island?
This is the south we're talking about, but we do take care of about 10% of the patients going to Crumlin are from the north, and so they don't have their own service. In the past, they had to travel to the UK for the service. So a number of them come to our service in Dublin.
And we would support them as well. So we would, we have a kind of partnership with Debra UK that we would, logistically, it's easier for us to get to the north of Ireland. So we support, a number of families in the north of Ireland as well.
So is there anything, like we're conscious that say you have a specialist area for cancers, it's a bigger amount of the population and so on. But is there any benefit, say, if there was, say there's a number of people based in Dublin, is there going to be, for instance, with the development of National Children's Hospital, you know, and I'm listening to what you're saying in relation to the specialist nurses and the 3 hours, and you know that clearly needs to be looked at. But is there space there within that development of the National Children's Hospital or will it continue in Crumlin, or I don't know, but
it will be in the National Children's Hospital. Yeah. And the beauty of that is you're close to the adult. St James's, it's the adult centre as well. So cross communication is vital, and the cross training, it'll be easier.
So again, those, you know, the specialist nurses and that, you know, is there an advantage of getting the bandages changed at home? You know, I suppose you have an independent life, you know, or is it, you know, would it be beneficial to have it done centrally? And you know, no.
3 times a week, it's not practical.
Exactly, and I mean we've got patients in Cork, Galway, everywhere, so it's not feasible for them to come up every second day. We've got a patient who gets bandage changes every day, so it's not feasible for her to travel to the acute.
It's also less stressful. Like when you come in, when you find that when they come into hospital, stress is induced on the way into the car park. So at least at home, you're doing everything you can to alleviate that unnecessary stress on an already stressful situation.
Yeah, we want to minimise the number of visits to the hospital, because even travel to the hospital from Donegal, say, damage to the skin, just being in a car for that length of time.
Yeah.
So we very much want, and so do our families and our patients, want care as much as possible close to home. And that's Sláinte Care's objective. We're all for that.
Again, I'm just trying to tease out, you know, what would be the best model in relation to, you know, they said, you know, it doesn't make sense that people have to try and travel long distance, and, you know, again, just to look at the cancer model, you know, that, you know, we were recently up in Altnagelvin Hospital, and there were, you know, people from Donegal can go to that as the nearest specialist area, and I'm just wondering, you know, if you have those clusters in a particular area, you know.
We do have dermatology departments around the country, and we've worked with those, and so they can manage a certain amount of the complications and issues. So we do have that relationship with the dermatology departments.
Again, you were talking in terms of the medical card. You talked in terms of the cost of, you know, the physical cost, the mental cost of it, and we touched on that. The actual financial cost, and I suppose that ranges if it's severe to mild or medium, or whatever it's, you know, the wording you use. Have you got it roughly?
We can tell you that there has been research done in that area, but the research has been somewhat hampered by either the sample sizes are too small into looking at costings, or that they have bunched everything together, you know, all the simplex and all the other subtypes bunched together, as opposed to costing them individually, you know. So it works out that the direct costs for a patient with the more severe form, recessive dystrophic EB, is about 79,000 a year, and that equates pretty well with the UK's figures, but we're not sure that these records are accurate, our studies are accurate, because of the reasons that I mentioned. And if you count direct and indirect, some research has been done on that in Ireland, Dara Flannery, and they've estimated at direct and indirect being about 130,000 a year. But I think that's spread over everybody, you know.
And it's very small sample sizes.
There was only about 14 in the sample size.
No, I think there's only about 6 actually.
6,
so we have a lot more. Yeah, and we'd like to do more research on that, but it's obviously time consuming, and we don't want to add extra burden to the patients who are already coordinating all the care for their children. So, but we would like to do more research into that.
It's in your strategy plan.
Yeah.
Again, apologies for focusing on the financial element of this, but have you worked out, you know, what it would cost the Exchequer, for instance, for, you know, to give everyone a medical card to the long-term payment?
No, we haven't.
Is there?
We need to.
We can work on that, yeah.
Again, because it's such a small sample, you know, that you know, in the overall health budget, it's, you know, it's quite small, but it would be, you know, as you explained this morning, it would be really significant for those families and those individuals that are left in. Again, you know, I'll give a commitment that we will try and follow up on many of these issues. I think my colleague John Lahart is looking to come in now at the end.
Briefly, yeah. Thanks, Chair. And I wasn't here for all of this, but I was listening to much of it. So I'm struck by it's 3 women that is representing Debra as well. Is there does that reflect a breakdown in those who experience the condition, or is that just...
No, but there would be about 87% of the people that we engage with would be females, but they would be mothers of people with EB generally. The carers generally tend to be mothers.
The mothers do the immediate caring, and the fathers do all the bureaucracy. I think sometimes in the family they both help. And in fact, actually, it has become a problem in one of our patients when the father was doing the dressings and the girl reached puberty. They had to back off, and so mother was left with just herself. So that was an issue.
Yeah.
Can we make one comment? Is that Debra is paying for nurse hours to the tune of 82,000 a year, and it's because when the care package, when the child goes to 18, they go from the public health nurses to the disability services, and Deirdre probably knows more, but they found that the disability services don't have the resources to fund these nurses. That's what you've been told.
Yeah, so exactly. So as somebody gets older, the condition progresses, and so a lot more care is required. And as we mentioned earlier, we're quite good at getting the 6 weeks old baby's care package in place, which is in 18 hours a week. That, as the child gets older, it's becoming a real fight to get those packages expanded. And then when you max out into 18 into disability services, you move into disability services, and there's no funding there. Like we've had funding rejected for hours for an adult last year. We needed 10 extra hours for her care, and it was rejected, which means that we're funding it since 2019. Again, we have a 10-year-old in Dublin who has requested an additional HCA for 9 hours a week, and that has been rejected. So there seems to be a lack of understanding that this is a requirement. This is an absolutely vital requirement, and we get them over the line eventually, or the parents get them over the line eventually. But it requires a huge battle on occasion to get that.
I chair a kind of an ad hoc cross-party committee on rare diseases, and so it's not an official Oireachtas Committee like this. So first thing I would say is thanks for alerting us to this. There's a conference, I don't know whether you're represented tomorrow in Farmley, the rare disease, so I hope to be out there for an hour or two in the morning. And certainly, I'm sure I speak for my colleagues too, I don't need to, this has been an education, and if there are a list of things, like please do, took a note of that last one, but if there's don't be shy. I'd welcome, and I know the chair would welcome, all members would welcome, write the parliamentary questions for us and we'll ask them, and kind of can shake the tree that way, and then we'll see what the formal answer is. Just two questions, if I may, briefly, Chair. You mentioned that there are treatments on the horizon. Can you say how far that horizon, how far away it is, and what those treatments might be?
Yeah, so unfortunately, this technology development does take time. There's a number of treatments going through clinical trials at the moment. With the way EB is, there's 4 subtypes, but there's many different subtypes under those as well. So a gene therapy won't be one type fits all. It's going to be very specific to certain types of EB. So we find, hopefully in the future, that each person who's living with EB will have a combination of different treatments to control their condition, similar to cystic fibrosis. So we spend a lot of money and a lot of effort into funding research. We partner with the Irish Research Council and the Health Research Board to fund researchers in Ireland developing treatments, and also with the Debra's across internationally on funding international research. So we hope that these will all go through that process, which takes years. However, there are things coming through the pipeline in clinical trials, phase 1, 2 and 3. Again, they need to go through those clinical trials, which take years, and then move on through the EMA and then the NCPE. So realistically, we have one treatment, which we discussed earlier, that has been submitted to the NCPE, and we're hoping to get a decision around that in the next few months. And then we have the first gene therapy, which will be submitted. It's currently in the progress of being submitted to the EMA, and it's already available through the in America. The FDA approved it, I think, last year, and it's having a significant effect on people with recessive dystrophic EB, a certain type of severe EB. So the horizon is looking good, but again, we're talking a long time before we see really significant differences.
Final point I would make. So we very often, I know in my first term as a TD, you know, you're kind of hit with everything, and if you're lucky enough to, fortunate enough to be elected a second term, privileged enough to be elected a second term, you kind of, certainly in my case, you kind of say, okay, you can't solve every problem. Let's try and advocate for maybe some key ones. So the rare disease became an area of interest for me, and so to take, for example, Huntington's disease. So we went through a process. We had them here. They presented to members of the Oireachtas in our what we call the AV room.
Yeah.
And while we haven't got a pathway of care for them, there have been some quite pronounced improvements there. So maybe through the chair, that's a facility that's open to you to seek to come in and where you'd address members. I mean, they'll be coming and going because there's lots of stuff on. But it gives you your kind of 45 minutes, and it kind of just raises the profile, and the profile piece, I think.
We did that, yes.
We've done it.
You've done it in this term?
October 2023, we launched this report.
Great, okay. And that was here?
It was here, yeah.
And in previous years we've done it as
Yes,
well.
we've done
Okay,
it.
so
Yeah.
sorry for teaching my grannies how to. It's okay, metaphorically speaking. Well, look, if there's PQs you want us to kind of ask, very happy to do that.
Great idea.
Yeah,
Thank you.
and
I suppose the positive thing is that, you know, you're praising the work of the HSE, and it's always good to, you know, to hear that this thing's working within the system itself. We hear a lot of negativity about our health service, but there's so many people that rely on it, and it's really positive. We will try and follow up with the care pathway with the HSE, where that's at, and maybe some of the other questions in relation to the medical card, the long-term illness, the points you were making this morning about how
bus passes or
the parking disc, all those, and also I was struck by the idea of the bandages being delivered, in another jurisdiction. Again, it'd be useful even just to get a sense of how much that would cost the exchequer relation. But they're all things that we certainly can follow up as a committee. If there's anything else you feel that you've missed this morning, let's have this as a start of a conversation with ourselves as the committee. And I think it was really useful. Certainly, I think it's useful for anyone listening at home. Any of those families they're not forgotten about. We are concerned about what their families and their loved ones are going through. It's really good news that there's possible research down the road that is positive news for all families, but there's a lot still we can do while we're waiting that. And you say about the specialist nurses and so on, that again there needs to be particular attention to that, and hopefully over our report from today that we will, there will be some sort of positive recommendations from ourselves in relation to that. So again, thank you for your time and your involvement with the committee this morning. I think it was a really useful session, and hopefully we can follow up with some sort of positive news for those families who are in that situation in the future. So again, thanks Representative Debra for their engagement with the committee on this important matter. The meeting is now adjourned until the 5th of March at 4 p.m. when the committee will meet in private session. So again, thanks very much. Okay.